This episode of Transmission Interrupted was recorded February 12th, 2026. This is Transmission Interrupted, a podcast series from NETEC, the National Emerging Special Pathogens Training and Education Center. Welcome to Transmission Interrupted from NETEC.
Hello, and welcome to Transmission Interrupted. My name is Jill Morgan. I'm a nurse here at Emory University Hospital in Atlanta. For those of you not yet familiar with NETEC, our mission is to set the gold standard for special pathogen preparedness and response across health systems in the U.S., with the goals of driving best practices and closing knowledge gaps and developing innovative resources. NETEC works alongside and in cooperation with the CDC and is funded by ASPR, the Administration for Strategic Preparedness and Response. And that's exactly what we're going to dive into a little bit today, which is where we started, how we came to be as NETEC, and why. So I get the opportunity to talk with three of the NETEC leaders, our principal investigators. That's usually sort of a research term, may not be familiar to people outside of academic medical centers or other research areas, but it means that these leaders are responsible for what happens with grant funding and overseeing NETEC's mission and management and finances. So these three represent NETEC's three founding institutions of University of Nebraska Medical Center, Emory University, and New York Health and Hospitals Bellevue. And we're going to look back to where we as an organization and they were a decade ago and where they see us going in the future. So I am thrilled to have today people that I have a tremendous amount of respect for. Dr. Aneesh Mehta, who's the professor of medicine, chief of infectious disease services, and the assistant director of transplant infectious diseases at Emory University Hospital in Atlanta. I have Dr. Vikram Mukherjee, who is chief of critical care at New York Health and Hospitals Bellevue, associate professor of medicine in pulmonary critical care and sleep medicine at NYU Grossman School of Medicine, and he's the chief of the Bellevue Special Pathogens Unit, and John Lowe, who's a virologist and environmental scientist at the University of Nebraska Medical Center, where he's also the executive director of global health security and the director of their Special Pathogens Unit at UNMC. So welcome, guys. I'm thrilled to have you, and I'm so glad you could carve out some time for today.
Greetings, Jill. Happy to be here.
Absolute pleasure, Jill. Thanks for having us.
All right, let's take a look into the Wayback Machine. Vikram, I'm going to start with you. I think that you are maybe the youngster of this group. What were you doing a decade ago that led you into this world?
Great question, Jill. So back in 2014, when Bellevue was just about entering the world of high-consequence infectious diseases, I think almost a decade and more behind Emory, Nebraska, in 2014, I was a pulmonary critical care fellow here at Bellevue. But in absolute awe of my predecessors, Dr. Laura Evans and Dr. Amit Uppal, who not just prepared Bellevue for a safe, effective response in New York City, but were the clinicians in the room along with Director of Nursing, Trish Tennell, to take care of Craig Spencer in a safe, effective manner without any healthcare workers being infected. So I was in absolute awe of the response and the preparedness efforts that went into it in a very accelerated manner, but also absolutely surprised by the entire ripple effects that surrounded patient care response between public health and media and the entire eyes of the nation watching patient care. I think that took me by a lot of surprise as a young fellow going through somewhat of a response adjacent role at that time.
Well, and certainly in critical care, you think about all the things that put people in ICUs across the United States, sepsis and respiratory failure and things like that. And the care you ended up delivering or that was ended up being delivered at biocontainment units was not that different, but certainly not what you might have expected when you got into critical care medicine. A little different for Aneesh. So Aneesh, you a decade ago were coming at this from a little different angle.
Yeah. So Jill, you know this as well as I do. So Jill Morgan, for those of you who don't know, was part of my training. So when I was a resident and fellow, Jill was a MICU nurse and was part of my bringing up as a doctor. We happened to be the physician and nurse on call when the Emory unit was activated in 2014. And I had the pleasure, and the anxiety was quelled by working with a partner that I had worked with many years. So yeah, we started out, I think, as you mentioned, doing what we normally do every single day in the hospital, but not knowing exactly how that was going to go in this special setting. And then as that response grew, we got to work with the great team at the University of Nebraska Medical Center. Remember being on call with Shelley and Phil Smith in those early days, working all together, figuring out how we were going to do this. And then later, of course, the great preparedness of the New York City public health system and New York City Health and Hospitals, reaching out to both of our institutions to work with all of us. And we all learned together and we grew together. And it's been an organic family growth for the past decade plus.
Yeah, it's interesting to me. You guys almost each have an aspect of NETEC within your own backgrounds, right? Like the critical care and the importance of that level of medicine. And then you have infectious diseases and really being on the lookout for these things. And then you have Dr. John Lowe, who is coming at this really from the virology, laboratory science, environmental science, of safety kind of aspect. So, John, a decade ago for you as a virologist and really thinking a lot about what we would think of as maybe environmental and occupational health risks, what was happening in your world 10 years ago?
Oh man, Jill. So you said it. I'm the non-clinician of the group, which is always interesting, right? Especially in a very clinically focused stream of work. But I was brought into the Nebraska Biocontainment Unit years before as part of my doctorate program by Phil Smith and Shelley Schweedhelm to really bring science and to push forward an interdisciplinary lens to how the Nebraska Biocontainment Unit developed protocols and things. So I was a few years post PhD, right before the 2014 Ebola outbreak. I was having a bit of an existential crisis, Jill, where at that point in time, these high-level isolation units were really fledgling and in a tenuous situation where I was in a new faculty role focusing my scholarship on biocontainment unit operations. So how do we bring in science of virology and industrial hygiene to answer questions that the clinical care team had that there just wasn't evidence for, and trying to generate our own evidence. So things like, how do we decontaminate a patient room after viral hemorrhagic care? How do we know if the way that we're using personal protective equipment is actually safe and effective for our care providers? So doing a lot of that. But at that point in time, there was no interest of funding agencies in supporting that work. In June of 2014, we actually had a meeting where we reviewed that our annual operating budget to sustain readiness of the biocontainment unit was about $17,000. And
Wow.
for us, this was a crisis moment where we came together as a small leadership team and said, we think we can commit to this for one more year, but we're not sure we can sustain readiness of a clinical care team for high-level isolation with this amount of funding. And so for me as an individual, I was kind of at this point where I was like, I've maybe made a huge mistake with my career choices and should maybe start looking at a completely different path. And then as Aneesh said, things changed really quickly to where perhaps the irrelevance of what we were doing and we were spending a lot of time focusing on, all of the sudden became very relevant and very crucial, not only to ourselves, but to our health system, the U.S. health system, and probably most importantly, the frontline healthcare providers that were deployed for that 2014 West Africa Ebola outbreak.
Yeah, really important to put this in place because you mentioned, John, sort of that late spring, early summer of 2014, where we were watching from afar, most of us, really the terrible loss of life that was going on in West Africa at the time with an Ebola outbreak. So in some ways, looking back, I think, well, gosh, if we weren't willing to fund it then, when there was all of this stuff going on, yes, I can imagine from your perspective, it'd be really discouraging for all of you to think about how are we ever going to convince people that this is a smart thing to do if we can't do it now? So I want to kind of pivot to when did you realize things were changing and going to change a lot? I think, John, you just alluded to that, but Vikram, really, like, did you see after the team at Bellevue had taken care of your patient, did you see that this was going to be something that was going to take off? I mean, did you really feel like, oh yeah, this is a time of change?
That's a great question, Jill. And, I think the Bellevue experience with Ebola was honestly a wake up call. And I think just looking at the last 11, 12 years since then, that wake up call has proven true. That, yes, we had a few Ebola patients here, but that's not once in a lifetime experience. With many factors, be it global warming or increased human to animal interface to increased international travel, these outbreaks, wherever they start on the planet, will come to US shores. An outbreak for anyone becomes an outbreak for everyone. I think it was towards the tail end of the West African outbreak is when the team here realized that the threat's going to come to your doorsteps. Whether you prepare is your choice, but the threat's not going to avoid you. So might as well invest in preparedness. Make sure two priorities that the patient himself or herself gets good standard of care. It shouldn't be a patient that's relegated to a corner of an ER and everyone's so scared that he or she doesn't get the care that they need. And the healthcare workers, which I think I've repeatedly mentioned, is the strongest asset for any healthcare delivery. A hospital bed is useless if we don't have physicians, nurses, respiratory therapists providing care. So making sure that they are safe in a high-risk environment such as an HLIU is a high priority for us. So I think that was a wake-up call that, yes, Ebola came to our shores, but these things, as we saw in the pandemic, as we saw in Mpox, will be recurring themes for the near future.
Yeah, a high level isolation unit may not seem like something everybody needs until you do. And then everybody wishes they had one, but you won't. So I think you're absolutely right. We have to work on this idea of ready or not, something will come. So you were all in this sort of stage and really contributed to the readiness of your facilities and then coalesced into what has become NETEC. Can you walk us through, Aneesh, maybe a little bit about how that happened and a little bit, maybe, I know we don't have a lot of time, but a little bit about NETEC between 2014 and where we are now?
Yeah, so I've been reflecting a lot, as we all have, on how we started and where we're going in the future. So, it's really interesting just picking up from what Vikram's been talking about. I think what brought us together at NETEC were events like what happened in New York. And most specific to our origin is actually not only what happened in New York with a domestic case, but a domestic case in Dallas, Texas, that actually then led to two healthcare workers getting infected. And that really sort of opened my eyes to a different paradigm of what we'd prepare for, at least at Emory, right? Which is really controlled transport of patients into our setting, being able to care for them, knowing what to expect. And the fact that we had cases that were discovered in the United States and particularly led to transmission to our colleagues, I think that was not only eye-opening for all of our teams. I remember on a conference call with the team at UNMC at the University of Nebraska talking about this as it was unfolding in Texas, and then being part of the care. And I think that's what drove us all together. But most importantly, for our funders, the Department of Health and Human Services, the real understanding that the U.S. healthcare systems needed to be prepared for this, not only to care for the patients, but really to protect our healthcare workers, our colleagues, and to make sure that the continuity of care of all of our patients was able to continue and be supported appropriately. And so I think in those discussions, our three institutions came together very quickly. And I really would turn it over to Dr. Lowe, who was very much a leader in those conversations of how NETEC developed. But in my perspective, I, again, was a clinician and a clinical scientist and was just really excited to see leaders like Phil Smith, Bruce Ribner, Laura Evans, Shelley Sweetham, Trish Tennell, Jill, and then our PhD scientists like John Lowe and several others, and also administrators. So we had strong healthcare administrative leads that worked at our three institutions to bring all of this together, because I think what we realized in our teams is that it cannot, one, be hierarchical, and two, it can't be just based off of what an infectious disease doctor thinks or what a critical nurse thinks or critical care docs. It really required all of our disciplines to work together and to design a integrate and fundamental training and education center that touched all those disciplines and integrated them into one system of care.
So Aneesh, like what you flagged is just, we lived this same experience in October of 2014. You just described a lot of that for me, to where even after Emory had taken their first or one or two repatriated patients from West Africa, Nebraska, we had taken a repatriated patient from here. There was still a dialogue, Jill, that had preceded this and was still going on, which is these specialized units or programs that focus on this are probably appropriate when we are intentionally plucking a highly hazardous patient from a location and deciding where in the US to drop them for care. Because there's a lot of geopolitical implications, there's a lot of that. But the debate that underpinned that was that the US healthcare system is really robust, it's highly resourced, and we have accreditation standards, and we deal with infection prevention control on a daily basis. And so there was this dialogue that underpinned that all the way up until September 30th, 2014, and into October, that was any hospital in the US at that point in time should be able to care for a patient and prevent that patient from infecting healthcare workers and other patients. And I think that we didn't realize it at the time how much hubris was driving that perspective of the US healthcare system's capacity, right, Jill? And so
Yes.
September 30th, 2014, this patient presents, who had traveled back from West Africa, presents to a hospital in Dallas. And there were a number of things that were not implemented at that particular hospital or in that health system because they didn't have a special pathogens program, right? What played out was that the patient was misdiagnosed, sent home. There was broad exposures in the community and in the health system. The delay in care for that patient, I think, escalated their illness. By the time they got definitive care, it was almost too late. It fractured the confidence in the US health system overnight to where we saw nursing unions in Dallas and in New York and across the country going on strikes and marching in the streets saying, we're not safe to provide care for this. And so the net effect of that, right, was that it took these few programs that were maintaining, barely on a shoestring, these capabilities, and it pushed the approaches to infection prevention and control, patient care, and all of the wraparound things like attending to family, supporting their loved one who's admitted, working with public health in the community to the forefront, as this is a model that needs to be validated across the country. So, and Jill, I think you are part of this. I know Marshall Lyons from Emory and I deployed to New York in November to go look at 3 or 4 hospitals in New York and look at their readiness to receive patients like this. And this happened rapidly. This was the Rapid Ebola Preparedness Initiative that CDC marshaled. As a result of it, over about 30 days, we, in partnership with APIC and CDC and Emory, Nebraska, visited and assessed the readiness of 50 hospitals across the country. And this list was published, right? These are 55 hospitals that have had some level of assessment and are ready to care for these patients. And it immediately kind of de-escalated the temperature of US healthcare providers that, okay, there are places where we can send those patients if they come to our site and we'll be safe. And that really led to a series of events that the formalization of training, of assessment, and of standard setting opened the opportunity to create this national center to really attend to that for the country. And when that opportunity dropped, it was initially worded as, we're going to fund one entity in the US to do this. And I remember it was, I think within 3 days of that dropping, Jill, a group of us convened in Atlanta at Emory. Bruce Ribner, Laura Evans, Phil Smith. I was lucky enough to be in the room. And it took about 15 minutes of conversation about there's this opportunity. We've all had this collective experience. But we think what the nation needs is something that's backed by all 3 of us. And in that room that day, we agreed to form a consortium and kind of stand up the nucleus of this national center. It did require that we went back to the federal government, ASPR at the time, and say, could you rewrite the opportunity and allow a consortium, a group of partner sites to do this together? And they did, and we kind of proceeded from there.
That's fantastic. Vikram, I want to give you the opportunity to really kind of talk about the vision you have for where we need to go, where you see us going, what the barriers are to getting there. Because I know that you had some thoughts on that.
Thank you, Jill. And as John and Aneesh were mentioning, we shouldn't have the hubris that every single hospital across the US can take care of high consequence infectious disease patients. Back a few years ago, there were 10 respects, along with a couple of pediatric partners. A few years ago, they went to 13 respects. But even that leaves massive, massive gaps in US territory for patients to come and present in a frontline hospital. And it's tough for a frontline ER to have the same level of preparedness as a well-resourced respect. Great news, earlier this year, NETEC announced 54 new level 2s on the NSPS map, and hopefully over time, those will come to capabilities to providing safe, effective care. But I think the biggest challenge that where I want to see this going is we have those mountains of gaps covered so that a patient, wherever he or she presents, can have the same level of safe, effective care. Healthcare worker safety and good supportive care gets met wherever the patient arrives. Of course, easier said than done. This needs funding. So far, we've relied entirely on federal funding. I would love to see some more private partnerships being built because when, for example, during COVID, a city like New York City shuts down, huge amounts of GDP drops. I know I was looking at the numbers, the US GDP dropped $14 trillion. And that doesn't even negate the fact that we have had 1.2 million deaths in the US from COVID alone. So I think to get to a state where we have not just these centers of excellence, the 13, not just the 54 level 2s, but more capabilities across the US needs funding. And I think instead of going into the boom and bust cycle where there's an outbreak, funding pours in, peacetime, funding recedes, we need to advocate and continue to press for sustained federal and public-private partnerships to make sure that preparedness is key to any response.
I think that's well said. And certainly we think about preparedness in other ways in our lives, right? I mean, how many of us have smoke detectors in our house? Have you ever had a fire in your house? Would you think, oh, I haven't had a fire in my house for the last 5 years. Let me just get rid of these smoke detectors. I don't think most of us would think that way. And yet people feel like, oh, we haven't had one of these happen in a while. We don't need to fund that. Kind of scary. So it sounds like to me, and again, I was sort of immersed in Emory's program, but really not thinking about anything global until we got the call that we were going to get a repatriated human. Our unit was designed really to serve just the interests of our CDC neighbors in case somebody got exposed in the field or in a lab. So we weren't expecting something like a sick human coming from another country. But it seems like we went from this will never happen to, well, everybody really should be ready to, well, let's make some places that are specialized and ready. And now in many ways, we've gone back to this idea that maybe we really can make everybody ready. And that's a big lift. And so I want to explain a few things that we've been probably referring to with acronyms. So NETEC started out as a National Ebola Training and Education Center, NETEC, and that's because our funding was specific to Ebola. And now, as we think more about special pathogens, we've expanded that to the National Emerging Special Pathogens Training and Education Center. And we have what we call RESPECT facilities, Regional Emerging Special Pathogens Treatment Centers. And there are 13 of those across the country. As Vikram just said, we've now funded 54 additional level 2s. So if you think about the trauma network, you have a level 1 trauma center, can handle anything, level 2, most things really well. We need more level 2s that are out there. And so now we're funding 54 and getting them to the point where they feel confident accepting a patient like this. But this idea of a national special pathogen system of care actually integrated into the US healthcare system is so gosh, I'm not even sure what adjectives I should use. It's big, it's complex, it's overwhelming to think about. It's a lot. So tell me what y'all think about this future of this as a special pathogen system, not just these little polka dots of people that might be prepared.
Yes, I'm happy to jump on that. I think one thing that we know is that 13 highly specialized, small capacity facilities are never going to meet the needs of a country the size of ours geographically and from a population standpoint, right? On the flip side of that, Joe, you nailed it. We can't shoot for an endpoint where every hospital in the country is a definitive care site for this type of thing. So I do think that this envisioning of a system with levels of care defined that can be applied throughout the U.S. healthcare system to make sure that some of the core lessons learned that we already flagged, right? So some of the things that we saw back in 2014 in that Texas experience are addressed system-wide. Our ability to identify and diagnose any patient that walks in anywhere in an effective way so that we limit secondary transmission to loved ones, to community members, to healthcare providers is really the goal, right? And that we can initiate definitive care as fast as possible in still protecting all of those populations. So a big part of it has become defining these different levels. And each level, as you go down in level, there's a smaller capability set and a higher number of facilities across the country that can provide that. And for those frontline facilities that are throughout the US, where if you're sick, you could go to any one of these and present, and you really need them to figure out what you have and to provide you care in a way that doesn't threaten others. So that's really what the foundation of the system that we're shooting for now is, some kind of minimum capabilities that we have distributed across the US that really drive for identification, right? That this is a disease that we're managing, an ability to effectively isolate those cases, and to inform the overall apparatus of the system, government agencies, higher level care sites, to make sure that we can marshal all the resources that we have in the US to provide care. I think the reality that's driven that forward is the standard of care in the US. And this is part of what we got past the hubris with this acknowledgement, which is we are not okay in the US with saying, you've got a disease you're probably going to die from, go sit in the corner, or here's an IV, and standing back, right? Our healthcare providers, day in and day out, throw everything at saving lives. And that doesn't change because it's like a highly risk pathogen. So that is what really drives this need for a higher level of readiness and a robust, sophisticated system.
Yeah, I agree completely. Aneesh?
I think, John, you said it very eloquently. I go back to what you were just talking about, Jill, this cycle that we've gone through in this thinking, right? The hubris that we really all could do this, should do this. The US healthcare system, as John mentioned, I think we all had this facade that we could just take care of everything that came at us and we're ready because we're highly resourced, and realizing that that is not always true and not in the way. And then we created these specialty centers, but then other things let us know very quickly that 13 sites are not enough. And we've come back to this cycle where everyone needs to be prepared. But I think the maturity in what NETEC has conveyed and what ASPR has conveyed is that everyone needs to be part of this solution, but everyone doesn't have to play the exact same part in that solution. And I really credit a lot of this to Shelley Sweetham, who really took the conversation about the NSPS strategy and really helped us with the system of care group, working with hospitals of all types, partnering with Paul Bittinger, really put together some great thoughts on minimal capabilities at each of these levels that had been defined, and how people can easily obtain the right level, the right minimum capabilities for their setting, so that we really figured out the way that everyone can participate, but we also make sure that we can have the appropriate levels of care when needed. And we know this has been successful in many other systems of care here in the United States and around the world. I think in the US, we have an amazing system of trauma care and a great system for burn care and stroke care. And so we've learned from those lessons that, again, everyone has to take part, but everyone's role is a little bit different. And the other thing I would add is touching on what John was just talking about. Our healthcare workers are built to take care of people and they want to take care of people. So we have to create structures in which they can safely and effectively care for individuals. And we talk a lot about this, particularly in academics, of what that pathogen in the room is and what tests we're going to do and what treatments we're going to do. But the crux of the system, and Jill, this is something you and nurses like you have taught me from the very beginning of my training, is in that room is a human being who's part of our community, that's part of a family, just like our family. And the people, regardless of what their role is, going in and out of those rooms are also human beings that have other responsibilities and want to care also for that human being in that room who is sick and care for their colleagues as well. And so I think that is part of the driving culture of NETEC, and we brought that culture of humanity in science and in medicine and our approach to special pathogen care into what is the NSPS. And again, it gets right back to everyone takes part, everyone plays their own role, and working together, we have an integrated, sustainable network of care.
Yeah, and I want to, just as the non-clinician in the group, the national group, I want to be just the hype man for a minute for you two, right? Because we've talked a lot about the system and protecting different communities. At the end of the day, it's about saving lives. And the fatality rate of patients that were cared for in the US was different. They received a different level of care. I mean, the work that you two did at Emory that really set the roadmap for the rest of us. I think that the first to do dialysis, the first to intubate, these are types of advanced supportive therapy we would have never dreamed of providing to patients with a disease that's highly lethal and easily transmitted. And so the reality of what's created in these spaces of these care units is the ability to really provide deep, advanced care. And what we learned is that these diseases that in some cases have well over a 50% fatality rate, we can buy that down to 10%, 15% with the level of care that we are able to provide. But the trade-off is the risks increase when we do those interventions. And so back to the hype man, what you guys did at Emory before anyone else in the world had done it was really groundbreaking. And I think really gets back to why we do this. It's not just about preventing secondary infections. It is about saving lives of the patients that present. And that is uniquely possible for these types of pathogens in this space. As you were saying that, Aneesh, I went straight back to remembering as we were preparing to take our first patient and watching everything that was being done at Emory and realizing these advanced interventions work and we can do them. It's not easy. We have to do a lot of planning, but this is why we do it. And then to see patients walk out the door and be hugged by their care team and their families. When they were brought to us, nobody envisioned that was a possibility.
Yeah, no, it's absolutely possible, John. And I appreciate being prompted to think back to that because we really did have patients that were brought to us thinking that they maybe had been brought back to the United States in order to just die here. And what a terrible psychological place that is for them to be in. And we really did feel like if we could do it safely, we were going to try to do it, no matter what it was. So we could deliver the same level of care that we deliver in our intensive care units every day. That's the goal, I think, for everybody. But we have to marry it with staff safety. And I think to me, this is what, I tell people, this is the hill I am willing to die on, which is we have to elevate staff safety. This is not a situation where people can be cavalier. It literally would be like running into a burning building without any fire protection on. We can't let people do that. We have to raise the level of awareness about what PPE does and doesn't do. We have to raise the level of understanding about infection prevention and control and using the right tools for the right job, and just making sure that the care we want to deliver doesn't bring with it any unnecessary risks. And I mean, I tell people this all the time, I get it. I was an ER nurse in a 36-bed hospital. When somebody runs in the door carrying a limp child, I'm going to take that limp child, right? PPE be damned. But if I've got somebody with a fever, cough, travel history, rash, nausea, vomiting, diarrhea, all right, ding, ding, ding. You've got a travel history. You've got symptoms. I'm putting on PPE. I'm putting you in isolation. We're going to deliver great care, but we're also going to protect ourselves. We're at 10 years and we've done so much and we've touched so many people across the country. I am so grateful for the opportunity this has given me to go out and teach what I would consider the gospel of PPE. But I think that there's so much more to do. So I just want to spend a couple of minutes with you guys thinking about what are concrete next steps? What can other places do, other facilities? What should we be asking when we are in front of our governmental relations people, or we're in front of our church giving a speech, or whatever we're doing? Where do we need to go with this?
Yeah. Well, I'll jump in and then let John also contribute some important information. Just building on what you just talked about, and now I'm going to be the hype guy. So I think as healthcare workers, we go in and we want to take care of patients. What you guys have both brought from the clinical perspective and the scientist perspective is how do we do this well and how do we do this safely? And I think it would have been really easy and probably my instinct to say, well, we took care of 4 patients. None of us got sick. We probably did it all right. And we did do it safely. None of us got sick. But people like the two of you were like, but okay, how are we going to do it better the next time? How are we going to keep more people safe? How are we going to make sure that a different type of pathogen doesn't get through our protocols and our barriers? I remember as we were having those early conversations in NETEC and seeing all of John's papers and like, oh, wow, there's a lot more to think about than I've been thinking about. And then in COVID, just watching the great work that all of our sites did, but thinking about how we decon things appropriately coming out of John's group. And then you, Jill, really driving us to think about beyond what people tell us protection does, what does it actually do for us? And how do we make that better? How do we work with these tools better and integrate them better? So I feel fundamentally we are safer in the work that we do in biocontainment care, high-level isolation units today than we were 10 years ago. And I'm very confident in 2, 5, 10 years we'll be even better off and better able to care for individuals. And I would not have had that thought process without folks like you pushing and bringing that to NETEC. I think it's really important as we have these discussions. One of the differences between what we do in special pathogen care and what happens in burn and what happens in trauma is those events don't affect usually the health of the caretakers, the caregivers, but these events do. I think the other fundamental part, and that has to be part of the conversation, is that these events like trauma, unfortunately, and burn, unfortunately, happen on a daily basis in our country. Fortunately for our communities, high consequence infectious diseases don't happen very frequently, and we want to keep it that way. But the flip side of that coin is because it doesn't happen, it is not on the front of everyone's mind all the time. And it takes major events, as Vikram mentioned. We have to make sure that we that have been part of this, we that have seen patients go through this, have seen that concern in our colleagues' face as they're thinking about doing this, to make sure that it is on the front of the minds of our healthcare systems, of our government officials, and in our communities, to understand that we're out there working very hard to make sure that we're all safe and be able to do the work that we do, and that unfortunately, while not frequently, these events will eventually affect Americans. But also, to put a silver lining on that particular part of the cloud, is that work that we do in this preparedness and the care that we give actually makes us safer, not only as healthcare workers, but as communities in the future. And one example that I think has been really insightful to me are things that I've heard from Dr. Brantley and Dr. Crozier well after they were no longer our patients, is that when they've gone back to Africa, they have seen the work that our three institutions and other institutions in the United States, whether it be getting a piccolo device or some sort of ability to look at electrolytes into the field, the protective equipment that is usable for human beings for more than 30 minutes into the field. And because of that fundamental work that I think our three centers did in our care, and then putting it into the scientific literature, training people on it and showing its effectiveness, has actually allowed the care in the places where a lot of these outbreaks occur to greatly improve, protect healthcare workers there, protect American citizens who are there, so that we don't need to transfer people back frequently. People who do come back and travel back are safer doing so, and their communities are safer doing so. So I think keeping all of those in the forefront of our colleagues in healthcare and our community members is really important to our mission sustainability.
Thanks. All right, John, your turn to just wrap it up, knock it out of the park, just finish us off here.
What more can you say than that? I agree with Aneesh, and that was really eloquent. I think it's about saving lives, right? And you underscored the translation of some of the lessons learned from our dedicated and highly resourced health system and units to really frontline where outbreaks occur, solutions and implementations. Measuring and managing electrolytes, not something that was doable or there wasn't a commitment to do at some of these outbreak sites. And now, whenever there's an outbreak, there is a will to make sure that that's part of the response. And that's just one example of many. So I think a big part of it is addressing the lessons learned that we've been able to develop from a small number of patients, but in a high resource setting, and figuring out how can we get that to where these cases are occurring at the highest level is a big part of it. I think the other, Jill, I'm probably oversimplifying, but I always go back to this, which is we can build the best, most effective system in the world to save lives. But if we don't know when we need to use it, it's not any good. So for me, it really does continue to come back to two things: astute clinicians, like ability to recognize what you're looking at and what needs to be done with it. And the other is a distributed ability to diagnose. So we are still run into challenges. And I think we saw this really great vignette with COVID, where we as a country struggled to marshal a distributed test to diagnose if someone had COVID or not for months into COVID. That is emblematic of something a lot of people are familiar with, but it's emblematic of our US health system's ability to diagnose for diseases we don't see regularly. And so I think it's important for us as a country and us as a special pathogens collective to really advance and think about how do we diagnose better. And this is applied in two ways, Jill. One is there's pathogens that have existed for decades. We know what they are. We know what they look like. How do we develop diagnostic tools that help us identify them quickly and readily at the point of care? The other is that we are living in a new world where synthetic biology is a thing, and pathogens that have not existed for decades, that we've never seen before, could be introduced and could be presented. And how will we even start to figure out what we're looking at and diagnose it? But I think we have this awareness and we have the technology, so advancing our ability to identify what's in front of us so that we can marshal these resources and this advanced system of care effectively is a huge priority, I think, for the next 5 to 10 years from my perspective.
Excellent. I so appreciate the opportunity to talk to you guys. This is something that has become a passion for me and a real driver for this season of my professional life. And I think while these are rare events, I want to loop back to something Aneesh said, which is preparing for special pathogens can make us better and keep us safer from the everyday things. And when I'm teaching the identify, isolate, inform, and initiate care model, one of the things I say is if somebody has a fever and a cough, I don't care what it is. I don't want it. If you've got a fever and diarrhea, thank you. I'm going to back up. I don't want any of those things, whether it's your cold or your flu or your norovirus. I just don't want it. And therefore, we need to put into place, I think, a thinking at the triage level, at the first points of entry. If this is something I don't want to take home to my children or my parents or my spouse or my partner, I need to make sure I'm protecting myself. And if I do that, I'm going to be much safer whether that next human has influenza or the next COVID or MERS or Ebola. We need to think infectious disease. We need to think about it being something that we can protect ourselves from instead of having a fatalistic attitude that I completely admit I had. I'll probably be MRSA positive anyway, just from all these years in healthcare. What the heck? No, I don't want to have all the rest of the stuff. Thank you very much. So I'm grateful for the opportunity that NETEC has given me to preach the gospel of better healthcare worker safety and better knowledge about PPE and really driving this idea forward that we can deliver great care in a safe environment, that we can keep our community safe, and that it doesn't have to be awful experience for our patients, that we can deliver great care to them and their loved ones. It's just been an honor and a privilege, and I've been so grateful. So I will not be here for the next 10-year reunion, but I greatly appreciate these last 10 years with all of you guys.
Jill, I just really enjoyed this look back and look forward. So thank you so much for hosting it.
Yeah, same here. I just am so appreciating this moment in time to reflect and think about how we all went through something really crazy and unique together. And to be able to spend 10 years continuing to work together. I think sometimes my family and my kids are like, what? This is such a weird work thing because you guys are all so close and you do so much together. But we have become family through a decade of really incredible and unique circumstances. And I just really appreciate the opportunity to kind of reflect on that with you too.
Yeah, thank you. It has been a tight-knit club, and we would like to expand our membership, please.
That's
so
right.
Healthcare communities across the country, we want you to join us.
Absolutely.
All right. Well, thank you to Vikram and to John and Aneesh, and thank you for joining us today as we talk about this origin story of NETEC and where we hope to go with the National Special Pathogen System of Care. For those of you listening at home, thanks for tuning in. We hope you'll join us for future episodes on a wide range of topics that are interesting to you, including healthcare worker safety and, of course, personal protective equipment, occasionally some stuff about trash, and more about infectious diseases of all kinds. If you have questions for NETEC or ideas for future shows, please feel free to contact us at info@netec.org or find us on the web at netec.org/podcast, where you can also subscribe to future episodes and find more information about NETEC and today's guests. So thank you again, and we'll see you next time on Transmission Interrupted.
You've been listening to Transmission Interrupted, a NETEC podcast, produced and edited by Benjamin Madsen, with additional support provided by Britton Clark, Veronica Lavaro, Jason Noble, and Lisa Stone. Special thanks to our guests and the subject matter experts at NETEC for their insight and guidance. This podcast is supported by the Administration for Strategic Preparedness and Response. For more information, tools, and training on special pathogen preparedness, visit netec.org. And don't forget to subscribe, rate, and share the show on Apple Podcasts, Spotify, or wherever you get your podcasts. Thank you for tuning in to Transmission Interrupted.